Diabetes Connections is brought to you by OneDrop, created for people with diabetes by people who have diabetes. And by Dexcom. Take control of your diabetes and live life to the fullest with Dexcom.
This is Diabetes Connections with Stacey Simms.
This week, we're talking about the youngest people with type 1 diabetes, babies and toddlers. At that age, everything, food, sleep, communication, has unique challenges, including what happens when you dose and they won't eat.
At that point, panic sets in. And as you know, children learn very quickly. And those children many times would hold out for whatever it is that they wanted. And so you can imagine the parent getting out the ice cream or the chocolate milk or whatever it is little Johnny wants, little Johnny's going to get.
Pediatric endocrinologist Henry Rodriguez is the clinical director of the University of South Florida Diabetes Center. He's actually referring to the older insulins there, NPH and regular, not commonly used anymore, but that situation certainly still happens. And we talk about everything from diluted insulin, breastfeeding, and CGM use. In Tell Me Something Good, the other end of the spectrum, celebrating a long life with type 1, 64 years since diagnosis and going strong. This podcast is not intended as medical advice. If you have those kinds of questions, please contact your healthcare provider. Welcome to another week of the show. I'm your host, Stacey Simms. So glad to have you along. And a special welcome to new listeners from the Greater Western Carolinas chapter of JDRF. Attended that summit over the weekend. So hello to anybody who found out about us there and is tuning in for the first time. And hello to all the moms and dads of little ones. This is an episode focusing on babies and toddlers with type 1 that I've actually been trying to do for a very long time. It is hard to find an endocrinologist who really wants to come on and talk about this. I don't know why, but it's taken a while. So I'm so happy that Dr. Rodriguez decided to spend some time with us. Now, as you know, if you're a longtime listener, the subject of babies and toddlers with type 1 is very near and dear to me. My son was diagnosed right before he turned 2. So I want to tell you right now, this is a longer episode. But please stay with it. Come and go as you please. We will be here waiting for you. You can certainly pause and come back. It's a longer interview, but I wanted to really take advantage of having a peds endo who could talk about this stuff. And the interview transcription is available at the episode homepage. Go to diabetes-connections.com, click on this episode, and you will see the transcription just a little bit down the screen there. That's new for 2020. Read the show. I know we're well into January at this point, but my house is finally a little bit back to how normal is now, I guess, because my daughter just went back to college. She's been home for about a month, which was fabulous, but she was definitely ready to go back to school. And I don't know when I'm going to see her again, and maybe just until spring break. Oh, my goodness. Benny is back at school. He goes to regular high school, so he went back earlier in January, and I was able to really take some time over the break to spend time with them, to catch up with them. Did a little bit of organization for the podcast, I can't lie. But while most people have been back to work and their routine for a while, I feel like we're really just hitting our stride now and getting into ours. And one of those things involves new sponsors on Diabetes Connections, and I am so thrilled to have OneDrop along this year. I spoke to the people at OneDrop, and I was really impressed at how much they get diabetes. Their CEO, Jeff, was diagnosed with type 1 as an adult, and OneDrop is for people with diabetes by people with diabetes. The people at OneDrop work relentlessly to remove all barriers between you and the care you need. Get 24/7 coaching support in your app and unlimited supplies delivered. No prescriptions or insurance required. Their beautiful, sleek meter fits in perfectly with the rest of your life. They'll also send you test strips with a strip plan that actually makes sense for how much you actually check. OneDrop, diabetes care delivered. Learn more, go to diabetes-connections.com and click on the OneDrop logo. My guest this week is Dr. Henry Rodriguez, a pediatric endo and the clinical director of the University of South Florida Diabetes Center. As Dr. Rodriguez confirms, as you'll hear, more younger people are being diagnosed with type 1, a trend that seems to have started about 15 to 20 years ago. but there's not a lot of easily accessible information to help parents in this age group. I will link up some information in the show notes on the episode homepage, including a couple of Facebook groups that I do recommend for parents of very young children. But when Benny was diagnosed, we really didn't know anybody with a child that young. And I felt like we were making up a lot of it as we went along. Now, the good news there is that he's fine, although I certainly made a lot of mistakes. But when you're talking about babies, 6 months old, 1 year old, it's a totally different ballgame. So if you are new to the show, I just want to warn you, I think I talk more in this interview than I usually do. Definitely get on my soapbox a few times, and you'll hear me pushing my opinions and pushing some of them onto Dr. Rodriguez, and he pushes back a couple of times, which is great. I feel very strongly about this age group. This is my wheelhouse, but of course I am not a doctor. So here is my interview with Dr. Henry Rodriguez. Dr. Rodriguez, thank you so much for talking to me. I'll be honest, this is an issue I've been trying to cover for a long time, and I'm thrilled that we're finally getting to talk about it. So thanks for coming on.
Oh, it's a pleasure.
I'm not even sure where to start. Between my personal experience and then talking to so many moms of babies and toddlers, let me maybe back up and ask you, as a pediatric endocrinologist, when somebody comes into your office or you meet them at the hospital and they have a child under the age of 2, where do you go? What do you tell them? How do you start?
Well, I think, we certainly start with the basics in terms of, what we feel the etiology of type 1 diabetes is, how we think, it develops. I think what we end up doing as clinicians many times is whenever a child is diagnosed with type 1 diabetes, even though we fully appreciate as providers that it's treatable, there's that sense of loss and mourning. So I think acknowledging that, and then we try to really focus on the fact that it is a treatable condition. It is challenging. There is no question that life is going to be different as folks head home, but it's manageable. And at our center we have the luxury of a multidisciplinary team, and we're all about supporting that family. I think there are 2 times of life, at least in the pediatric age group, that are particularly challenging. It's in the very young children, and then it's the children that get diagnosed around the time of adolescence. And so for the very young child, the bottom line is it is extremely important that we tailor the therapy to the patient. It's true across the board, but I think particularly with the youngest ones.
When you're talking about the youngest ones, I think as we go through this interview, we will kind of section it, because obviously there's a difference between a 6-month-old and a 16-month-old, and a 3-year-old. But my personal experience was interesting. So when my son was diagnosed, our pediatrician, he was not yet 2. It was about 5 to 6 weeks before he turned 2. She said, bring him in. It sounds like type 1 diabetes, but he's too young. I've never had a case of someone under the age of 2, so bring him in and let's rule it out. And luckily, we brought him in. Unluckily, we ruled it in, obviously. But is that something that was either common at that time, which is 13 years ago? Does it still happen that people think you can't possibly have type 1 if you're under a certain age?
No, I think, what we encounter typically is at the other end of the spectrum. It's,
right.
It's adults that come in, and the assumption is, well, you're an adult. You obviously have type 2 diabetes. You couldn't possibly have type 1. But I will tell you that I oversee both adult and pediatric providers at our center. And, historically, pediatric endocrinologists, pediatricians will assume it's type 1 until proven otherwise. And on the adult side, it's the opposite. So I think we are in less danger of mismanaging, so to speak, a young child, because our kind of default is to treat those children with insulin and then, figure out the rest afterwards. Elevated blood sugars can occur transiently in a child who's ill, in the midst of stress of illness. And we can kind of say, well, okay, let's just see how things go. Now, obviously, if you have a child that has an extremely high blood sugar, that has, positive ketones, possibly acidosis, well, then it's insulin deficiency, and so you proceed in that regard. But, for a child that comes in with, let's say, RSV pneumonia, and you get a few elevated blood sugars, we'll let that slide, so to speak. But for sustained high blood sugars, we always resort to insulin therapy.
Okay, so it was just maybe my pediatrician's personal experience hadn't borne that out. It wasn't something common. And before I move on from that, I had heard anecdotally again that there are more cases of younger children with type 1 in the past 10 to 15 years than there were, say, 30 or 40 years ago. Is that true?
Yes, it is true. Unfortunately, we know that overall the incidence of type 1 diabetes is increasing, and that increase has really most affected children less than 5 years of age. I should mention before we move on, and we're going to come into the youngest individuals, as you said, but for children less than 6 months of age, one thing that always factors into the equation, particularly if there's any kind of, multiple family members that are affected by, quote, type 1 diabetes, we also have to think about monogenic diabetes. Those are individuals who have a genetic mutation that has affected the machinery, as it were, that's necessary to monitor the blood glucose, to, make the insulin, store the insulin, release the insulin, all those things. Now, it's far less common, but we have to think about those things in the youngest individuals.
And I will say, as you listen, we will link up information about monogenetic diabetes in the show notes. You can find it on the website. And I'm actually doing a show in just a couple of weeks with a family that thought the child had type 1, thought the parent had type 1, but it turned out it was monogenetic. So we'll be talking more about that in a future episode, but more information, because as we're talking about the youngest kids here, that is something you absolutely have to keep in mind. All right, so let's talk practical, because most of the questions that I have taken from other parents and that I had myself, I remember when my son was diagnosed, were about precision of dosing. I mean, it's so hard, right? I mean, when Benny was diagnosed, he was a bigger kid, luckily, so we were not using diluted insulin, which I'll ask about. But we were drawing up quarter units, which are not measurable. They don't make there's no lines for quarter units, or at least there weren't on a syringe. There wasn't even a half unit pen at that time. How do you advise people to do these itty bitty teeny weeny doses for kids?
Honestly, I am, so you mentioned we would get to it, but I'm not a great fan of diluted insulin. I think you can do that. Perhaps you could accuse me of a bit of paranoia, but I'm always concerned that either, less likely on the part of the parent, but, another caretaker and so forth, an error at the level of the pharmacy. I'm always concerned when you dilute insulin. If you're diluting the insulin tenfold and for some reason you make an error and you deliver the full strength insulin, that's 10 times the dose you had intended giving. So that is, as I said, there may be a little paranoia on my part. I try to get away from that. I will tell you, as you mentioned, even with the syringes, there are now insulin syringes that have half unit increments. And when you say you're going to measure a quarter unit, you have to understand that you're giving between 0 and a half. You're not giving a quarter of a unit.
And my quarter unit was not my husband's quarter unit. We knew that. We were just trying our best.
Exactly. But I think that's where I generally move towards, in fairly rapid progression, move towards insulin pump therapy.
Okay, wait, but before we do, you jumped right in on diluted. Let's continue that, because I do think it's worth talking about. We never used it. I didn't even know it was an option at that time. But when I see people talk about it, they seem very enthusiastic about it. Before we go any further, and I'm happy to, like as you said, on the one hand it's the paranoia, on the other hand are the parents who do think it works well. But let's start with the facts. What is it? I mean, you're not diluting insulin at home, are you? Does the pharmacy do it? How does it work? Oh, my goodness.
Yeah, you can go one of two ways. I mean, the manufacturers do provide, you can purchase a diluent. It's essentially the solution that insulin is prepared in, and you can dilute that insulin. Some folks do that again, you kind of segued off of the insulin pump therapy. You can do it with a pump as well. But you dilute the insulin, and it's something that my preference, if you're going to go that route, is to get a reliable pharmacist to do that for you. But there are some individuals that do it at home.
Okay, so this sounds like a very foolish question, but I don't. We're just at the beginning here. How do you do it? I mean, do you literally take a regular vial of insulin and then dilute it at home with? You pull it out. I'm trying to think of how I would do that.
Well, you have a vial of the diluent, and you introduce however many units of insulin into that. We used to do this back in the old days with growth hormone therapy.
Ah.
We could tailor the concentration to provide a volume that was reasonable to inject. It's certainly doable, but I generally prefer to go with simpler, never going to be foolproof, making it less likely that an error is going to occur.
I know that people really have good success with it, but it would make me very nervous, as you said.
Well, I share that sentiment.
Does it go, insulin we know has a shelf life, so to speak, out of the refrigerator for 28 days and in the refrigerator for the date that's on the packaging. Does diluting it change that?
It shouldn't, but obviously, as you indicated, you want to do it in as sterile a fashion as possible. And again, I'm stating the obvious here, but we say 28 days. It's not because on the 29th day, the insulin no longer functions. It degrades over time.
Right.
And considering, particularly when you're dealing with small doses like this, and considering the accuracy that we try to achieve with regards to dosing for the individual carbohydrates, for the correction doses, if on day 45 your insulin is 90% as effective as it was in day 1, that's not ideal. So that's why we generally encourage people to rotate out the vial or the pen every 28 days. Now, in a child that isn't using very much insulin, that means you're disposing of a lot of insulin. There is a certain level of waste there. What we typically try to do is, your pens hold 300 units, your vials hold a full 1,000 units. I think if you're looking at it from an economical standpoint, even if you cannot use the pen to deliver the doses, you can draw from the pen with a syringe. However, I think it's incredibly important that folks understand that once you've done that with a pen, you're going to potentially introduce error to any insulin you deliver with the pen mechanism. In other words, you're changing the volume within that cartridge in such a way that if you then turn around and use that pen the way it's intended, you run the risk of inaccuracies in the dosing. So we always tell folks, once you've drawn from a pen with a syringe, don't revert to using that pen as an injection device by itself. Yeah.
We do that. We actually pull insulin out sometimes to use in the pump from a pen, but then you cannot use that pen to inject as a pen. That's it. It's done. Now it's just a big dumb vial. You can't use it anymore.
It's a little vial.
It's a little dumb vial. Okay. You mentioned instead of diluted insulin that you would prefer the precision of an insulin pump. And this isn't an editorial statement, but I'm just thinking, I remember when my son went on an insulin pump, he was 2.5. And I see these babies that are on insulin pumps, and the babies are so teeny tiny, and the pumps are so large. This isn't really a medical question, but they do okay on them?
They do. You make allowances. If you think about, so here is where your choice of pump is important. The easiest pump is the Omnipod. In terms of educating people how to use it, in terms of placing it, and so forth. The problem is, as you appreciate, the pod takes up quite a bit of real estate when you compare it with an otherwise traditional infusion site. So that comes into play as well. Typically you're placing the pod either on the thigh of an infant or on the buttocks, and changing diapers and so forth, that then becomes a potential issue there. So it is not without its difficulties, but it does allow you far more flexibility, far more precision in insulin dosing. And if you think about the youngest child, let's take an infant who's breastfeeding. Well, they're feeding every 2 hours. First of all, that's a lot of injections. I generally will prefer to provide insulin more physiologically. If the child is continuing to make some insulin on their own, you might be able to use a long-acting insulin to kind of cover things over the course of the day, but you're not going to achieve the degree of control that most folks would really see as the goal with just one injection of insulin. You can do intermediate-acting insulins, but then you're really requiring that you have regimented caloric intake, carbohydrate intake. And a very young child, or an infant for that matter, I think it's nearly impossible to ensure that.
Well, you brought up breastfeeding, which is on the list, because I see these moms. Again, my son was a little bit older. I did breastfeed, but it was done by the time he was 23 months old. But a lot of these moms are breastfeeding their kids with type 1 diabetes, which I think is unbelievably challenging because you don't know what they're actually eating. Even without diabetes, we worry about that. So what do you tell moms who want to continue breastfeeding? You mentioned a couple of different options there, but do you just check a billion times? I mean, how do you do it?
Well, again, not to put more hardware, so to speak, on this little one, but, this is where a continuous glucose monitor, I think is a lifesaver. It provides you with a lot of data, and breast milk changes over time, but you can certainly have the breast milk analyzed, and you can look at the carbohydrate content and so forth, but you still don't know what volume that child is going to take. So it is a bit of trial and error, quite honestly. I mean, so much of type 1 diabetes management is, but it really comes down to, per breastfeeding session, the blood sugar typically goes up X. We'll try, a little bit of insulin, and we'll see how that goes. And it really becomes trial and error. And this is where it is so much a partnership between the diabetes care provider and the parents. That many times ends up primarily being mom, but it is trial and error. We always opt, or the default will be, we want to be really cognizant of the risk for low blood sugars, so we don't want to overdose. We'll likely underdose. Until not that many years ago, we as a pediatric endocrinology community would say, well, it's a very young child. We might tolerate, A1Cs of 9, in some cases 10%. Now, I think nowadays, with the more rapid-acting insulin analogs, with the possibility of insulin pump therapy, with continuous glucose monitoring, all those things help reassure us and allow us to be more aggressive, so to speak. So we don't have infants with blood sugars that are routinely elevated. Once you cross that threshold of 180 or 200, keep in mind that that child is going to be urinating more because they're losing glucose in the urine. And so that creates challenges in terms of keeping that infant hydrated. And certainly you've got to get more calories into them because they're losing them. So it definitely is a complicated process.
All right. We have to stop you there because I have to go back. I've written a bunch of notes, and we're going to follow up on everything you've said. But there's two really dumb questions I do have to ask before we move on. And the first is...
No such thing.
Oh, well, hang on. So sending the breast milk out to be analyzed. Who is analyzing their breast milk? I mean, how do you do it? Is that something people should do in terms of the carb count?
Yeah, you can have that done.
Who does that? We have to. Is that a Google thing? We'll Google it and find a bunch of services that give me the calorie count.
No. I think you work with your healthcare provider and you can send it out to a laboratory and have that done. Okay. Now, I'm not saying absolutely positively has to be done all the time.
Sure.
I think in many cases that's probably the healthcare provider, the diabetologist, trying to get a better handle on things. And it makes the trial and error perhaps a little bit easier, but breast milk does change in its consistency and its caloric content and so forth over the period that the child is breastfeeding. So it's not foolproof. It's not as if you've got a nutrition label that tells you exactly what the makeup is of that breast milk.
It's fascinating. And then I guess that would be a lot of help for pumping breast milk as well, right? Because then you can really measure it.
Exactly. And again, as a pediatrician, we obviously advocate for breastfeeding. Breastfeeding's best. And pumping does allow you, particularly for, a child that maybe is having some challenges in terms of feeding on a routine basis or even, tolerating a large volume and so forth, being able to quantitate that, I think, goes a long way.
So you mentioned that in the past you would be okay, or you tell parents it's very reassuring to have an A1C of 9 or 10 at this very young age. And I assume that's because the alternative was so dangerous. You don't want the kids to be going low without CGM in the past, and without the fast-acting insulin is just so difficult. But I've also heard that in the past it was thought that there was some kind of protection when kids were very little, that the highs kind of didn't matter as much. Am I correct in thinking I heard that somewhere? And is there any truth to it?
Yeah. No, you are correct. And so the way I used to think of it is, well, people didn't think that, with regards to complications and serious consequences of high blood sugars, that clock didn't start ticking until after puberty, to which I think that's pretty ridiculous. Unfortunately, over the course of my career, I have seen very young adults that poorly controlled, and in young adulthood, they're suffering the ravages of high blood sugars. They've got renal impairment. They're having issues with their sight and so forth. We can't do that. And as you've indicated, I think this is where continuous glucose monitoring allows us to be far more aggressive. No longer do I have to have a parent check twice a night, every night, to make sure that that child isn't having low blood sugars overnight. And so as a consequence, I can be more aggressive and say, well, no, we don't have to have that baby go to sleep with a blood sugar of 200 because we're worried about lows. We can target something far lower because we know that we're going to be able to, in the case of a Dexcom, for instance, that it will alarm, that it will notify the parent that there's an impending blood sugar, and you can intervene before the child actually goes low.
Before we go on, I just want to be clear, and maybe this is a bit more of an editorial statement, but I think you'll back me up. When you're saying that the concern about babies and toddlers, going over 200, because, we're all looking at time and range now, those of us who are lucky enough to use CGM, which is usually 70 or 80 to 180. I don't want parents who are maybe newer diagnosed to feel like their kids are going to die or go blind if they hit 200, because obviously you don't want to stay there. You don't want to stay at 300. But can you give us a little reassurance that the concern there is just on a regular basis? You're worried about hydration. You're worried about long-term. But if your child hits 200, it's not the end of the world. I just worry about, I don't know. I'm all right, I'll let you talk. Sorry.
No. I really do appreciate you pointing that out, because there are some parents that, I think sometimes we focus on, this is the ideal. I think we're actually doing much better with CGM now. But, it used to be that the gold standard was a post-meal blood sugar that doesn't go over 180. You have to appreciate that even somebody that doesn't have diabetes does have a rise in their blood sugar after a meal, but it typically doesn't go above certainly 140. Right. So your point, I think, is well taken. We don't want the parent of any child, or a particularly younger child, to think, oh, my Lord, they've had several blood sugars of 230 over the last week. Horrible things are going to happen. That certainly is not the case. We do, for the reasons that you've raised, particularly with regards to hydration and just overall longer-term risk, we do want to minimize high blood sugars, but the occasional blood sugar over 200 is not going to have lasting effects on that child.
All right, which brings us to another topic that I think is really important and this is more toddlers than babies. But once they start eating, right, we all know that pre-bolusing is the gold standard. You're supposed to figure out, how far in advance. When my son was younger, we could bolus ahead maybe 10 minutes. Now we can pre-bolus 20, even 30 minutes for some meals. He's a big kid. He eats differently. It's a lot different to have a 15-year-old than a 23-month-old. But that also can be very complicating for parents who don't know what the heck their toddler's going to eat. I'm curious what you counsel people who say, how do I do this? My kid throws food on the floor, or he will only eat a cookie, or we sit down to eat and he takes 2 hours to eat breakfast. I have my own feelings, but I'm curious as a mom, but as a medical professional, what you tell people.
Okay. Management of type 1 diabetes is all about compromise. I think back to early in my career in diabetes is when the first rapid-acting insulin came on board, and that was Lispro or Humalog. And so prior to that, the recommendation with human regular insulin was to administer it 30 minutes before eating. And so I imagined the parents of a very young child, toddler, where they did what they were told, and then the child refuses to eat whatever they put in front of them. And at that point, panic sets in. And as you know, children learn very quickly, and those children many times would hold out for whatever it is that they wanted. And so you can imagine the parent getting out the ice cream or the chocolate milk or whatever it is little Johnny wants, little Johnny's going to get, because the consequences otherwise is that child is going to have potentially a serious low blood sugar. So the rapid insulin analogs allowed us then to say, well, Humalog, Novolog, Apidra have an onset of action about twice as fast as regular insulin. And so understanding that it wasn't perfect, but it was reasonable to say, well, if you're really, really not sure that child is going to eat, you can give the insulin after they're done. Now, if they take an hour to eat, that's going to be a problem because you're going to get a significant blood sugar rise before that insulin actually starts working. Keep in mind that even your rapid-acting insulin analogs, they don't peak for an hour to hour and a half. So if you're waiting to give the insulin after you eat, there's going to be a significant rise in blood sugar before it comes down. And this is where, again, you're now, for lack of a better term, ultra-rapid-acting insulin analogs that are now coming to the forefront work about twice as fast as your Humalog, Novolog, and Apidra. And so I think from that perspective, there's hope that we're not going to suffer from higher blood sugars just because we're giving insulin beforehand. The one ultra-rapid-acting insulin analog that is currently available is Aspart. It's rapid Aspart or Fiasp, and that's made by Novo. I know that, we're actually doing one study here at our center with the ultra-rapid form of Humalog. And so it's interesting because at least in the adult studies, that insulin given up to 20 minutes after the meal worked about as well in controlling the blood sugar as giving, ordinary Lispro or Humalog beforehand.
Oh, that's great.
Yeah, absolutely. So again, it's allowing us to be more aggressive and limiting the rise in blood sugar after a meal, even if it's given afterwards.
Yeah. And I will admit, we did not have a CGM until my son was 9 years old. And it came out before that, but frankly, I didn't think it was accurate enough at the time for what we needed, and he didn't want a second sight. I've told this story before. So we bolused after until he was probably 6 years old. And not having a continuous glucose monitor, obviously you're not seeing the rise of blood sugar because 2 hours later he's fine. But our A1Cs were always great. I really feel like it didn't hurt him for whatever reason to do it that way. He's also, though, he was a healthy eater. He did not take an hour and a half to eat a meal. He probably took 3 seconds to eat his food. So it wasn't really like we were waiting that long. But it really can be done. And I'll be honest with you, doctor, I really feel like, but this is a little soapbox moment. I just feel like you can create disordered eating, honestly, if you're not careful. And if your kid starts saying things like, I'm going to only eat the ice cream or I'm going to hold out for the dessert, there's really, and my heart goes out to parents who are so concerned about never rising over 120 or 140. Mm-hmm. I see these parents in Facebook groups all the time. And it's like, oh my gosh, your kids, I hate to say it, your kid's going to have diabetes for a long time. I hope there's a cure, but it's very difficult. So I appreciate you saying that. I appreciate you giving some hope about faster acting insulins. But just permission to bolus after is amazing. But also, you mentioned if they're going to eat for an hour. Again, with an insulin pump, it's so helpful because you can maybe bolus. All right, there's 25 carbs in this plate. I'm going to give 5 carbs up front. I'm going to give 5 carbs 5 minutes in, right? You can do it as they go, too, which is fabulous.
I think, if I may, I digress for a moment. I'm sure you've heard the term brittle diabetes.
Yes. Brittle diabetes.
And so I, early on in my career, admittedly, erroneously assumed that was a non-adherent patient. In other words, their blood sugars were far more difficult to control because they weren't doing what we told them as their providers to do. And over the years, I've come to appreciate that even though I still don't like the term, type 1 diabetes is not type 1 diabetes for everyone. We've done so much research over the last few years. There are individuals that have had type 1 diabetes, the gold medalists from Joslin, that continue to make insulin years and years later. And so for individuals that have, their pancreas is still making some insulin, it's far easier for them to have more stable blood sugars, as opposed to someone who's totally dependent on what we refer to as exogenous or injected insulin by a pump or needle. It's a different animal. And so, if you have an individual that is, if you think about it, has a prolonged honeymoon period, they're making insulin, some insulin, not enough, and the background kind of takes the edge off if you think about it.
Sure.
Not only, in that honeymoon period, not only are the blood sugars better controlled on the top end, but think about the risk for low blood sugars. It's less because, for example, if you're making 50% of the insulin you need and you're you're going low, you have the ability to turn off that 50%, at least in theory.
Right.
So that your body can respond by making less insulin, and therefore you have less risk for low blood sugar. So I think I've grown somewhat wiser over the years and really come to appreciate that, just because someone has erratic blood sugars, it doesn't mean that they're not following the management plan.
Absolutely. And then conversely, I will say, perhaps I was on my high horse, if someone has a good experience, it doesn't mean that's because they're doing everything right. I will also point out that for some magical reason, my son does not get ketones easily at all. It's been remarkable because it has, knock on wood, I'll knock on everything I can knock on, but, he just doesn't develop that. He's been sick just like every other kid. He's been high for days. He's a teenager. And he hasn't developed large ketones that I ever remember, where I have a friend whose kid hits 250 for 2 hours and he's got large ketones. So it's a great reminder that everyone's experience really is different. I appreciate that. Let's just talk a little bit. You mentioned the honeymoon period. I have heard, again, this is a lot of I've heard, can you confirm? But I have heard that when children get type 1, it is very acute. And almost always the honeymoon period is either short or, the insulin-producing cells are just gone. Is that true?
Depends.
Mm-hmm.
This is one of those areas. So you're probably familiar with type 1 diabetes trial net.
Yes.
And before that, it was the diabetes prevention trial. So we have been screening family members of individuals with type 1 diabetes to determine really, who's at greatest risk. And then in some cases, we've been doing oral glucose tolerance tests. Really, if you think about it, just kind of testing their pancreas to see if they can make enough insulin to keep the blood sugar in normal range, even with lots of sugar coming in all at once. And what we've found is that, the progression first tends to be more latent, slower in older individuals, and it tends to be most aggressive in the youngest, which is a little bit disheartening, but it is what it is. There was a publication that came out that was jointly authored by the Endocrine Society, JDRF, and the ADA. And this came out, don't quote me on this, you'll have to double check it, but I think it was December of 2016 or something.
I'll look it up.
And based upon, and I can provide the reference later on, but based upon largely all the individuals that we screened in TrialNet and our follow-up of them, what we have determined is that type 1 diabetes, you don't have type 1 diabetes when you end up with a high blood sugar and in the emergency room with your typical symptoms of, urinating a lot, drinking a lot, perhaps losing weight without trying. Those are the classic triad of symptoms that we associate with, gosh, you have type 1 diabetes. We can, and we have in TrialNet, tested up to 5 different antibodies that we can measure in the bloodstream that are a signal that the immune system has begun to identify the cells in the pancreas that make insulin, the beta cells, as, quote, foreign. And then the immune system makes antibodies that then target those cells. We can measure up to 5. What we've determined is in individuals that have 2 or more, their lifetime risk of developing type 1 diabetes is nearly 100%. So that's where it's now accepted that there's a staging system for type 1 diabetes. Stage 1 is when you have an antibody, at least, 2 antibodies of the 5. Stage 2 is when you have those 2 antibodies and on that oral glucose tolerance test, the stress test for the islet cells, that they don't rise to a level that the standard for diagnosing type 1 diabetes based on that test is a 2-hour level that's 200 milligrams per deciliter or more. So you haven't reached that threshold, but you're above the 140. And so you're in that gray zone. So that's what we refer to as glucose intolerance. It basically tells us that the beta cells are starting to fail, so to speak. That's stage 2. Stage 3 is when you have classic symptoms, when you generally present with clinical symptoms. And then stage 4 are individuals that have established diabetes for extended period of time. So to answer your question, the autoimmune process occurs in the background. And we are, as part of research studies, primarily TrialNet, screening individuals there are some related studies in Europe as well, but we're screening individuals that we know are at great risk or greater risk because they have a family member. Now, if I can go off a little bit for a moment, keep in mind that the vast majority of people that get diagnosed with type 1 diabetes do not have a family member. Okay, so somewhere around 90-95%. But for those individuals that do have a family member, their relative risk is about 15-fold greater. And you might say, well, gosh, that sounds like, that's terrible. That's really high. What you're basically looking at is a relative risk of about 5%. In other words, for every 100 individuals that we screen that has a family member with type 1, only 5 end up being antibody positive. If you were to look at that in the general population, it's maybe 2 or 3 out of 1,000 as opposed to 5 out of 100. So the risk is greater in family members, but the majority of individuals that do get diagnosed with type 1 diabetes, there is no family history.
It's so interesting. And that was us. We had no family history, like so many people, as you said. But then 3 years later, my cousin was diagnosed. So now we're thinking, is it something? Is it because we won't know? I mean, you really, I guess we won't know until the next generation, perhaps. But both kids have gone through, several of us have gone through TrialNet. So, nobody else has any markers. So we shall see. But it's a really good point. Yeah, I know. It's funny because it is great. And then I have to be honest with you. My first reaction was guilt. I mean, guilty that I didn't have it. And I would have felt guilty if I did have it because then I would have thought I passed it on. Oh, that's a different show. Okay. So we're going to run out of time. Yeah, exactly. Oh. I got a really interesting question that I wanted to make sure to address to you. And it was about food. And I know, you maybe I can have a nutritionist on and go into this in a more specialized way. But the question was, sometimes, especially with kids, we get these free snacks. You can have, I remember my son, it was anything under 10 carbs was a free snack. But the question was, low carb snacks are tough for infants and toddlers because at this age group, things like nuts and raw vegetables are a choking hazard.
Right.
Any ideas or comments on low carb snacks?
Yeah, it's a challenge. And if you think about it, even, breast milk, as we mentioned, or regular milk, there are some carbohydrates there. I think, it all comes down to, as we said, it's a compromise. You do your best. I have a number of patients who, we don't recommend this in younger children by any means, but there are adults, as you're probably aware, that find that their blood glucose control is far better if they really restrict their carbohydrates. Okay. And again, I want to emphasize again, in children, we generally discourage that because children need a balanced diet in order to grow and develop. But adults will find, in some cases, they severely restrict their carbohydrates. We're talking about 15 or 20 grams in an entire day.
Yeah.
Now, you might say, well, do they need insulin? Well, they certainly need basal insulin. You need that regardless. But for those individuals, we focus on the protein intake because protein will raise your blood sugar not nearly to the degree that carbohydrates do. But you need some insulin to cover that glucose rise that can occur with intake of protein. So in the absence of carbohydrate, we look at dosing for protein. But the short answer to your question is, it's going to depend on the age of the child, as you said, and youngest children, you don't want to give them foods that they may choke on. You should certainly bake snacks with almond flour and things like that where, you don't have that choking hazard. I think there are a lot more options out there now than there were in the past.
Another question I got was about communication because, and oh my gosh, this was so difficult for us. When you have an older child, they can tell you kind of how they're feeling, even if they don't have all of the hypoglycemia awareness and they're not really sure how they feel. When you have a baby, they can't, my son couldn't say diabetes. And how do you talk to parents about, I remember my biggest question was, well, is he napping? Is he low and passing out? We were just checking him. Again, CGM can be very helpful, but not everybody's going to have one. Yeah.
So in that particular instance, more and more, we try to get that child on a CGM as soon as we can. And we will go to bat for that family and we will try to get it covered through their insurance. We'll find a way because otherwise, parents are sleep deprived. They're monitoring that child overnight at all hours. So I think continuous glucose monitoring in that case is almost essential. We're at the point now where the devices are accurate enough. Certainly, we're well beyond the stage where the FDA said when they were first introduced that, you couldn't do any insulin dosing based on the CGM reading. So we know that they're accurate. We always double check with the blood glucose if we're concerned, but I think it brings so much value that I really strongly advocate for trying every possible means to get that young child on a continuous glucose monitor.
I'm sure if my son was diagnosed at that age today, I would push for it as well. But I do want to ask you one thing before I let you go here. You said parents are sleep deprived. I don't know if you're aware, you probably are, that even with CGM, and I actually think, again, editorial, in part because of it, that more parents are more sleep deprived because they cannot stop looking at the numbers. And it's not only that they can't stop
looking to their cell phone.
Well, exactly, please. But, you have your alarm set, but people either don't trust it or they're so worried. Or on the flip side, as we mentioned earlier, they've got their high alarm set to 125. So they're not sleeping even with CGM. What do you do about that? How do we balance this amazing technology that is supposed to give us less fear with this odd, I don't know if it's social media phenomenon or what's happened in the last 5 years where there is almost more fear in a way?
Right. So I think it really is a matter of education. And so I think that's where, in some cases you may be talking about maybe meeting with a psychologist to address those fears. But I always tell families, I never tell a parent that they should not check if they feel they need to check. But I do tell them that I would like them to get to a place where they feel comfortable sleeping overnight and not having to look continuously. And so that means ongoing communication with that family and working with their diabetes care team to get them to a point where they feel comfortable. That's critically important. Type 1 diabetes is stressful. I don't need to tell you that. But getting folks to the place where they feel that it's less of a burden and more of a benefit of a tool that will allow them to not worry so much. We're not at the point now where we have closed loop systems, unfortunately. We're getting there.
Right.
But if you think about it, even with a closed loop system, I can't tell you, it's funny, I've got patients now that have been on continuous glucose monitoring almost at the time they were diagnosed. And it was telling to me because I had a patient say, well, what did folks do before there was CGM? It's really interesting, but I will tell you, and not to put all the blame on the adolescents, but I've had adolescent patients that for whatever reason, their CGM, either they run out of supplies or, as you I'm sure know, a couple of weekends ago, there was loss of connectivity. Mm-hmm. Receivers would still work, but at any rate, they somehow forget that they have the ability to poke their fingers and use a traditional glucose monitor. Yeah, it's a challenge, but even when you have a closed-loop system, insulin's being delivered under the skin. You're dependent upon that little cannula that sits under the skin. So one of the things that I really, really focus on is kind of worst-case scenario. You don't change your site right before you go to bed. You want to make sure that you have the ability to observe either with a CGM or do a blood sugar check, an hour or two after you've done a site change, as a matter of routine, so that you know that the cannula is in place, that the insulin's being delivered and so forth. We always have to come back to basics. If you have a closed-loop system and there's an interruption in insulin delivery, you need to be aware. And so I think those are some basic skills that folks will have to still master even when we have closed-loop systems.
Yeah, that's at any age, too. That's great advice. All right, so let me ask you one more question here before I wrap this up. You are a pediatric endo. You've seen kids from infant age, as you said, and you do see some young adults. So what's it like for you to see somebody who was diagnosed as a toddler or a baby grow up with type 1? I'm sure you've had patients. I mean, we've been seeing the same endo for 13 years, and he's seen my son from a pacifier. I mean, my son would be mortified, but from a pacifier in diapers to now he's got his driving permit. What is it like for you to watch these kids grow up?
It's inspiring, actually. It's funny you should mention that. So I've been at the University of South Florida now for 9 years. And there's a patient that I saw at the time of diagnosis when I was in Indiana. And, we both ended up moving down to this area. And so it's a young lady who's now a freshman in college. And I saw her when she was diagnosed at 5 years of age. And she's just phenomenal. It really is a testament to her family. It's funny. People ask me, and for years they've asked me, well, how did you end up in diabetes? And I used to say that I don't have a personal connection to diabetes because diabetes is not something that's my family. My family's got other issues. But, Now I tell them I don't have a genetic connection because I have had really the great fortune of working with individuals in the diabetes community. As you said, it's a fairly small one, particularly when you're talking about type 1, but there are some phenomenal, inspiring individuals that really, when I have challenging days, I think of those individuals and it really does inspire me.
So as you're listening, and I know most of the listeners this week will probably be parents who have very young children, I still think back, Dr. Rodriguez, of when my son was diagnosed, and I thought, what is his life going to be like? It's not going to be the life I thought he would lead. He's not yet 2, and this is going to ruin things. And it didn't. Like I said, he's got his permit. He's healthy. He's obviously it changed our life, but my fears from that age didn't come true.
And again, every day, individuals in JDRF, the American Diabetes Association, really have made great strides. You probably heard of the ruling of the FAA just recently that, it used to be that I told children that well, what do you want to be when you grow up? And they tell you, well, I want to be a pilot. And that was not an option. Yeah. It now is. So I think the technology, the advances in therapies have gotten us to a place where you can do just about anything you want to do. We try to communicate that message to all of our families.
Well, thank you so much for spending so much time with me. I could probably talk to you for another 3 hours, but I really appreciate it. Thanks for sharing so much of your expertise.
Well, it's a pleasure chatting with you.
You're listening to Diabetes Connections with Stacey Simms.
I'll link up some more information, including the Facebook groups that I mentioned for the very youngest people with type 1 diabetes over at the homepage. And remember, on the episode homepage, you can find the whole transcription of this interview. I know it was long. I really appreciate that you stuck with it. Coming up in just a minute, tell me something good. We're going to go to the other end of the spectrum, not babies, but a woman who was diagnosed 62 years ago. Diabetes Connections is brought to you by Dexcom, and we've been using the Dexcom G6 since it came out, and it's amazing. The Dexcom G6 is now FDA permitted for no finger sticks for calibration and diabetes treatment decisions. You do that 2-hour warm-up, and the number just pops up. After previous iterations of Dexcom, which didn't do that, I am still getting used to that kind of magical pop-up without calibration. We have been using Dexcom for 6 years now, and it just keeps getting better. The G6 has longer sensor wear, now 10 days, and the new sensor applicator is so easy to use. Benny does it by himself. He says it doesn't hurt. Of course, we love the alerts and alarms and that we can set them how we want. If your glucose alerts and readings from the G6 do not match symptoms or expectations, use a blood glucose meter to make diabetes treatment decisions. To learn more, go to diabetes-connections.com and click on the Dexcom logo. It is time now for Tell Me Something Good, where we tell the good news in our community. And I got a great note in the Facebook group, and that's Diabetes Connections, the group. If you're not in there already, please go ahead and join. But Carolyn Thalman said that she is celebrating 62 years with type 1 diabetes. She writes, I was diagnosed at 11. I remember the pan my mom kept on the back of the stove with the glass syringe and steel needle that had to be boiled every morning. I took about 70 units of Lente insulin. I'm not even sure if I'm saying that right. One of my favorite stories, she says, is that one day my mom asked the pharmacist for a pumice stone to file a rough spot off a needle, and he yelled at her for not just buying a new needle. They cost 50 cents. I started MDI about 40 years ago and a pump about 25 years ago. I got a Dexcom 2 years ago, and I learned more about what my body does with food in that first year with a CGM than I had learned in the previous 60. Thanks for asking, she says. Well, Carolyn, thank you so much for telling us your story. And one of the best parts about her post in the Facebook group is that other people who've lived with type 1 for 50, 60 years chimed in and started telling their own stories. It's just so great to hear. And isn't it incredible to think about how far everything has come? I mean, you hear these stories, right? But here is somebody who lived it and is still doing well. Wow, Carolyn, I really appreciate it. Send me your Tell Me Something Good stories. We're sharing them on social media this year as well. It can be anything from a very big milestone diaversary to something your kid did that was fun to something you really just want to share. Maybe someone in your community did something nice. You can email me, Stacey at diabetes-connections.com, or post it in the Facebook group, or message me over social. Find me and tell me something good. As I mentioned in our last full episode with the time shiftiness of podcasting, Benny was supposed to get off crutches and into physical therapy, and I am thrilled to announce that he is. If you're new to the show, he tore his meniscus in October, and it has been a long road. He missed the entire wrestling season pretty much. It's almost over now, but he's doing great. He's been so patient. I mean, I got to give this kid some credit. It's been really tough, and he's done a great job. He has just had a really good attitude in a really crummy situation. So I'm really, really proud of him. We went to see our endocrinologist in the beginning of January. It was a great visit. He's had the same A1C for the last 3, maybe 4 visits, if not all 4. It's been very, very close, which we're really thrilled with. Going to be excited to see what happens with Control IQ and if that makes a difference. I can't imagine that it won't. Our next book stop is actually tonight. If you're listening the day this is released on the 14th, I'm heading to Columbia, South Carolina to talk to the JDRF chapter there. I'm very excited to share some world's worst diabetes mom stories. And then it's off to Raleigh on February 1st. We're doing a lot of stuff around the Carolinas, which I love. I live in Charlotte, North Carolina. I posted the complete book tour through March on social media, and you can see all of the stops at diabetes-connections.com. Just click on community. We have a short episode, one of our mini-sodes coming out on Thursday, and that is all about Control IQ. I did a full episode with all the information you need, and you can go back just a couple of weeks ago. That is with Molly McElway-Malloy. This episode is just my hope for Control IQ, my expectations, my thinking on hybrid closed loop, what I really think Benny is going to get out of it. So that's coming up in just a couple of days. Make sure you are subscribed to this podcast. If you're listening on a podcast app, hit subscribe and you will never miss an episode. Thanks, as always, to my editor, John Buchanan from Audio Editing Solutions. Thank you all so much for listening. I'm Stacey Simms. I'll see you back here on Thursday when we're talking about Control IQ.
Diabetes Connections is a production of Stacey Simms Media. All rights reserved, all wrongs avenged.